Hi, I'm Nadim Aslam. I'm an orthopedic consultant. I specialise in robotic surgery. This last year, 2025, we've come first in the country, so we're delighted with that. I'm going to go through a summary of what a hip replacement is and what our current feeling is in terms of technology and the way forward. A hip replacement is an operation which is designed to treat hip arthritis. Hip arthritis is when the surface of the joint becomes worn, the hips start to articulate bone on bone, which causes hip pain. Initially, the symptoms may be just on weight bearing. Eventually, as that process progresses, the symptoms become persistent during sitting and lying and disturb patient sleep. Eventually, the patient will reach a situation where the pain is intolerable and the quality of life is poor, and at that stage, the time has come to consider hip replacement surgery. A hip replacement consists of the following, and we can show you on this model that we have, on the one side we have the socket, the acetabulum. There the bone can be eroded down to bare bone. We prepare the bone with what we call reamers, and then we ourselves believe in uncemented sockets. So there will be a shell with a coating which the bone bonds onto. We will impact the shell into the acetabulum, and then we will impact a liner, which is a very specialized polyethylene, to allow that to make the socket component. On the femoral side, the bone is hollow, and the degree of bone strength depends on your age and various factors. And we would take a stem, which is traditionally a femoral component. It can be cemented in cases where the bone is weak. It can be uncemented in cases where the bone is strong. And the stem is placed into the femoral canal. And then my own preference is to use ceramic as a bearing because that has the best wear properties on the head side. Traditionally, we occasionally used to use ceramic on ceramic, but we felt that that bearing causes squeaking in some patients, and it has a higher risk of fracture traditionally. So we've now gone to using the highly cross-linked polyethylene on the acetabulum side of the ceramic, and together that forms the construct. Now, this construct is the same for most surgeons. The question really is, how do you execute that operation with the minimal pain, minimal discomfort, and the best outcome? Now, ideally, if we could put a joint replacement in, we would cause no damage to the soft tissues, we would cause minimal change in the position of the hip. That would be the best outcome. So that's impossible to do because it's an invasive procedure, but what we can do is try to minimize the degree of damage in that hip. And the way we do that is that rather than make an incision from the iliac crest down to the midpoint of the lateral aspect there, we make an incision from here to here. We go down onto the neck, we protect the muscular structures, we identify the capsule there, and then do a minimally invasive approach, which is a direct superior approach, which allows us to then cut the hip in position, remove the damaged part, and then build the hip in position. We've found, not only in terms of the recovery of patients, but also our PROMS data is amongst the best in the country in terms of recovery from that operation. Then, as well as the minimally invasive approach, we then started to look at other techniques, we felt that we could improve the accuracy and outcome of patients. For many years, I've believed in minimal reaming of the socket. There are some surgeons who carry out multiple reams, remove a lot of bone, and go deep on the socket. We believe that you should just remove enough bone to place the socket in the best position. And with the advent of robotic technology and planning, we essentially have gone down to 1 to 2 reams to get optimal positioning of the socket and the stem, which has minimized soft tissue damage, swelling, and that again, as well as the minimally invasive approach, has enhanced the recovery of our patients. So we're now offering minimally invasive surgery with robotic assisted technology. A routine case was involved somebody coming in for surgery. They would be going home either on the same day or the next morning. The pain would be controlled. We would have minimal pain relief. They would have a crutch to go home with initially, we would allow them to lie on their side straight away, and we'd be looking at driving within 2 weeks, and we would expect people to have pretty much full recovery by 6 weeks' time. So if you're interested or looking at further exploration for your hip pain and your arthritis, we'd be more than happy to see you. Thank you.